Hello everyone, you are welcomed to Anonymous Med Tech, and today I am uploading a presentation on amyloidosis. So let's begin. Now, first the definition. There are basically 5 words that are majorly required for the definition of amyloidosis, which I remember as happy. So here the Y is replaced by E. So here it is as H for hyaline, the pinkish color material. Hyaline substance, the hyaline substance. A for amorphous. Amorphous means something different, the texture which is different and appears as a cheese. Next up, that is P, which is pathological, and then again a P, which is proteinaceous. So it is a pathological, proteinaceous, amorphous, extracellular hyaline substance deposited in various tissues and organs of the body. So this is the basic definition of amyloidosis. Amyloidosis can be a potential long answer question. Now, next, moving on to the physical nature of amyloidosis. Amyloidosis can be seen under electron microscope and as in X-ray crystallography and infrared spectrometer. In electron microscope, it appears continuous and non-branching fibrils it appears as. Now in X-ray crystallography and infrared spectrometry, it appears as cross beta pleated sheet structure. Now if we do this is an extra edge. If we do a congruent staining of it and seen under a polarized light, it appears as an apple green birefringence. Just remember this, I'll explain it once again. And this apple green birefringence structure is actually occurring because of the cross beta pleated sheet structure of amyloidosis seen under X-ray crystallography or infrared spectrometry. Now moving on to the chemical nature. Chemical nature is very simple. The material which is deposited is a protein in nature and contains 2 parts of the protein, which are misfolded proteins made up of amyloid protein, which is 95%, and P protein, which can be a particular misfold protein, and which is 5%. Now moving on to the classification of amyloidosis. Amyloidosis can be localized, generalized, or familial. Localized amyloidosis, as you can say, the name itself suggests the one organ involvement, and in generalized there could be multi-organ involvement, and familial, it's actually hereditary. Moving on to the first type, that is localized. Localized is contains 4 examples. For now you have to remember the medullary carcinoma of thyroid. Remember this. There is somewhere else you'll remember the example of papillary carcinoma of thyroid. So you have to remember that here in amyloidosis you have to remember the medullary carcinoma of thyroid, and the material which is deposited is A-cal. A for amyloid protein, which is 95%, and cal is for calcitonin, which is 5%. The misfolded calcitonin, not the original hormone calcitonin. Now type 2 diabetes mellitus. In type 2 diabetes mellitus, there is accumulation of AIAPP. AIPAPP stands for amyloid islets associated pancreatic polypeptides. Amyloid islets associated pancreatic polypeptides. These are majorly the proteins which are misfolded proteins, and these are deposited mostly in the pancreas in type 2 diabetes mellitus patients. Okay, moving on to the Alzheimer's disease. In Alzheimer's disease, there is A beta amyloid protein and the beta protein which is deposited, misfolded beta protein. Next up, which is Prions disease. It is APR. APR is for A for amyloid protein and prion protein, again which is a misfolded protein. So the localized, we are done with the localized. Moving on to the generalized type of amyloidosis. Now in generalized type of amyloidosis, it can be further of 3 types: primary amyloidosis, secondary amyloidosis, or the reactive systemic amyloidosis. You'll understand why it's been named this way. Next up, the last one, which is chronic renal failure or a long-term dialysis amyloidosis associated with chronic renal failure. You can also pronounce it as amyloidosis associated with chronic renal failure or long-term dialysis. Now, primary amyloidosis, it is actually AL, deposition of AL it occurs, and it is kind of most common amyloidosis. The AL here, A stands for amyloid protein, again the 95%, and here the L stands for the L, light chain disorders, mostly the monoclonal antibody disorders. The plasma cells, the monoclonal plasma cells releases the monoclonal antibodies, and those antibodies contains the kappa type of L chain, and their deposition leads to primary type of amyloidosis. The most peculiar example for it will be multiple myeloma. As we all know, it's kind of the most common example for primary amyloidosis. Moving on to the reactive systemic amyloidosis or the secondary amyloidosis. Why it is named secondary or reactive systemic amyloidosis? Because it occurs or it's seen is secondary to any chronic inflammation condition or chronic neoplasms, like renal cell carcinoma. You have to remember just the examples you have to remember. And for the chronic inflammation condition, you have to remember tuberculosis, the most common type, bronchitis, inflammatory bowel disease, or rheumatoid arthritis. Now, rheumatoid arthritis is the most common. So, moving on to the pathogenesis of primary and secondary amyloidosis, this can be a potential short answer in your university examination. So, pathogenesis of primary amyloidosis, it occurs through a monoclonal B lymphocyte or plasma cell proliferation. This plasma cell proliferation leads to Ig monoclonal type of light chain formation, mostly the kappa types, for which the excess production leads to the AL protein deposition in almost all part of the body, like in generalized way. That is why it comes under the generalized amyloidosis. Now, moving on to the secondary type, chronic inflammation. We are taking an example as chronic inflammation condition. In chronic inflammation, the macrophages are activated. These macrophages lead to interleukin 1 and interleukin 6 type of release, mostly the 6th type. In the liver cells, they act on. The interleukin 1 and interleukin 6 act on liver cells, the hepatocytes, and the hepatocytes produce the SAA, which is serum amyloid associated. The serum amyloid associated, these are the proteins produced in the liver, and this in turn produces AA protein, which are amyloid associated protein. Again, these are deposited in various organs of the body and tissues, and thus known as generalized amyloidosis, the secondary type. Moving on to the third type, which is chronic renal failure. It's been separated out, or long-term dialysis. As we all know, in chronic renal failure, the patient is needed the dialysis, and as we do the dialysis, the hemodialysing membrane cannot filter out the beta 2 type of microglobulins. Especially the beta 2 type of microglobulins cannot be filtered out, so they start to accumulate in the body and thus leads to the deposition. Okay, so like this, as the beta 2 microglobulins are deposited in the body, they leads to A beta 2M. The M stands for microglobulin. Beta 2 type of microglobulins are deposited. A again is for amyloid protein, which is 95%. These are deposited mostly in the joints and tendons of the body. These are deposited, and this leads to carpal tunnel syndrome. Sometimes if it's deposited in the joint, it leads to the carpal tunnel syndrome. We all know it's the compression of median nerve. Now, moving on to the another miscellaneous type of generalized amyloidosis. It usually occurs or seen in aging people, so it's known as senile amyloidosis or aging amyloidosis. It's also known as cardiac amyloidosis. Now, in this, ATTR, A again it's for amyloid protein, which is 95%, and TTR is transthyretin, which is a misfold protein. Transthyretin is actually a protein that transports thyroxine hormone, T4 hormone, which is 5% again. It usually occurs in heart, that is known as cardiac amyloidosis. Moving on to the familial type, which is the inherited amyloidosis. In familial amyloidosis, it is of two types: the familial Mediterranean fever and familial amyloidotic polyneuropathy. familial Mediterranean fever and familial amyloidotic polyneuropathy. The familial Mediterranean fever, it is autosomal recessive, you have to remember this, and the familial amyloidotic polyneuropathy, it is autosomal dominant. In familial Mediterranean fever, there is AA deposition. Again, AA was also seen in the secondary amyloidosis condition. So again, amyloid associated it means, and it is usually deposited in serosal, peritoneal, pericardial regions, always in the layers or the walls of the organs and tissues. The familial amyloidotic polyneuropathy, it is an autosomal dominant disorder, and here the protein which is deposited is amyloid transthyretin protein. Again, there is a catch point here. In saline aging amyloidosis, the ATTR, this was a normal type. There was a misfold, of course, but it was still a normal protein. But here in familial amyloidotic polyneuropathy, there is mutant ATTR, the amyloid transthyretin protein, which is mutant, and this is deposited, and this affects the perineural system, peripheral nervous system, peripheral autonomic nervous system. It affects, and this leads to peripheral neuropathy or polyneuropathy. Moving on to the condition, these are the small table that I have made to actually make a brief of all the types of amyloidosis we have discussed till now. Now, if you like, you can have a screenshot of it. Moving on to the next, for the diagnosis of amyloidosis. I'm sorry, the video is a little hazy. Actually, I took it with a camera pic, so it's a bit hazy, but I would read it out so you can copy. So, the diagnosis for amyloidosis, we would do the biopsy of biopsy. Mostly it is done of kidneys are mostly done, because usually it's the kidney which are affected with amyloidosis. So we usually do the biopsy of kidney, and sometimes we do if there is systemic involvement, we would also do the systemic biopsy. For systemic biopsy, we mostly prefer the abdominal fat pad biopsy. This is literally important and most common. Other than that, we can use the rectal biopsy and the gingiva biopsy too, which is the gums. Okay, now the stains of amyloidosis, another hot topic for short answers for your university. Now, stains for amyloidosis, firstly, actually we should start up with the best stain, which is Congo red. So in Congo red, the amyloidosis, in Congo red stain, we should actually look for two ways: in normal light and in preferred polarized light. So in normal light, the amyloid will appear as salmon pink color. The amyloid will appear as salmon pink, mind my words, or typically red, but you should mention it salmon pink. In polarized light, it will, again, as I have already told you, it will appear as apple green birefringes, and this birefringes structure is actually due to the cross beta pleated sheet structure we have seen in the X-ray crystallography or the infrared spectrometry. Moving on to the other stains like H&E stain, the normal hematoxylin and eosinophilic stain, it appears pink as usual. In PAS, the periodic acid shift test, it appears magenta. In theophyllic ANI stain, it appears, it is actually an immunofluorescent stain. Next is methyl violet and crystal violet. In both of them, these are basic stain, so it appears metachromatic stain. These are the metachromatic stain. The final one is a gross stain. In gross stain, we paint the cut surface of the organ with iodine. The cut surface where we actually suspecting to have an amyloid, we actually cut the surface and put some iron. We paint the area with the iodine, and after putting in the iodine, it appears mahogany green, mahogany brown in color. This mahogany brown in color, if we add sulfuric acid to it, either if it appears blue or if it doesn't change its color. There are two options. If it doesn't change its color, it means there is no amyloidosis. But if it changes its color to blue, especially the blue, it means the amyloid is present and we are sure of it. Now, the organ involvement in amyloidosis, the final slide we are moving on to, the organ involvement in amyloidosis. Now, first up, the kidney, most common, usually involves the glomeruli, mesangial cells, and the capillaries. Okay, in kidneys, usually the glomeruli, mesangial cells, and the capillaries are involved, causes narrowing and obliteration of the lumens of capillaries and glomeruli. Of course, the amyloids are being deposited in the lumens, so it will lead to the obliteration and narrowing of the lumen of capillaries and glomeruli. Now, these are actually presented with the nephrotic syndrome. In kidneys, the nephrotic syndrome occurs, and it is actually presented with the nephrotic syndrome. Moving on to the liver, this can be a potential MCQ. In liver, the first organ which is affected, the first part which is affected, is the space of Dacey. Space of Dacey is a space in between the hepatocytes and the sinusoids. As you can see, I've marked the place. The hepatocytes and sinusoids, the area between the hepatocytes and the sinusoids, the space is known as the space of Dacey. So in this area, when as you can actually remember it very easily, once in the space, there are a lot of amyloid, the misfolded proteins are being deposited in here. So it can lead to the pressure atrophy. It can lead to the pressure atrophy of the hepatocytes and can lead to cirrhosis. Cirrhosis is the fibrous deposition of hepatocytes in the hepatocytes. So this is what will happen and will lead to liver amyloidosis. It is again a localized type, as we are talking about. In tongue, it can lead to macroglossia in patients. Now in heart, usually the affected area is subendocardial deposition. In the subendocardial region, it is being deposited. Now in clinical, it will be presented as a restrictive cardiomyopathy. Just remember the name. I am not very sure about this because I am as well a second year student. So a restrictive cardiomyopathy could be seen in heart disease. In patients with restrictive cardiomyopathy, the amyloidosis can be seen, most likely to happen. Now the most viva and important question point is spleen. Spleen, it can be of two types, as we know, the red pulp and the white pulp. So if it's deposited in the white pulp or the follicles, so it is called as sago-spleen. Sago-spleen, we know the sago, the sabudana, we say. So it appears as sabudana, so we call it as sago-spleen. And the lardaceous spleen, lal, you can remember from lardaceous, red in color, red pulp is involved, or if the sinus is involved, so it will lead to lardaceous spleen. That's all. Thank you so much.